And more folks will continue to come in, but we'll get things rolling here with our next session. This is the Coordinated Care Specialty session. We're privileged to have a number of expert providers here to talk about care and management for VHL-associated conditions and tumors. So Deo Bautista is going to moderate this session. You were introduced to Deo earlier. We have on our panel experts across the board. Dr. Vitaly Margulis, who you met earlier, is one of our outstanding urologists. Dr. Oksana Hamidi, who is our endocrinology specialist, and we'll talk about management of VHL-associated pheochromocytomas. Dr. Walter Kutz, who's one of our head and neck and ear surgery specialists, and Dr. Sam Barnett, one of our specialty neurosurgeons. So Deo, take it away. And Janet.
I just wanted to highlight how excited I am about this particular presentation. This is something that is new to our run of show. This is really going to hit home, I think, for some individuals with VHL and families. This is a live situation, right? You're going to see experts that are going to be treating a theoretical patient. And I think this is where all of this scientific stuff that you're learning is really going to hit home. So enjoy.
Hello, good afternoon again. My name is Deo Bautista. As I introduce myself to all my patients that come here, I'll be your advocate and liaison. Now I could add quarterback, just like what Miss Julianne told me earlier. And also a possible consultant to MOPIT if they try to build their nursing navigation program. Again, here are the panel of your professors, specialists, and surgeons that will be talking about screening and possible treatment. And first question is to, they have introduced yourself already, right? My first question is to Dr. Barnett. Dr. Barnett, we know that hemangioblastomas are one of the most common features of VHL. What does the screening for this condition look like here at UT Southwestern?
So thanks for having us. Typically, patients that have von Hippel-Lindau are going to get either annual or every other year MRI scans of their brain and their entire spine. That's the standard screening. Most patients will get every other year is more common, but if they have particularly aggressive or like high number of lesions, they might get annual scans.
Okay, and thank you. And now the next one is, I think, Dr. Kutz, you have some slides to show us, and I would like you to talk about endolymphatic sac tumors and how do you screen them, sir?
Okay, great. Well, thank you for having me. It's a great group, and I'm really honored to be able to speak with everybody. I'm going to give you those here. I had to stand up here so I could see my slides. I don't want to hurt my neck. Let's see if my slides are here. Oh, here we go. So, so about endolymphatic sac tumors, this group may have heard of those, but they're actually very rare tumors. And they can occur with von Hippel-Lindau, or they can also occur without von Hippel-Lindau. And I'm a ear, nose, throat surgeon, but I really only do ear surgery. So out of all the different conditions I treat, I may see an endolymphatic sac tumor once every 2 or 3 years. And that includes having a very busy von Hippel-Lindau practice. And so fortunately, it's rare. It's quoted about 10 to 15% of patients with von Hippel-Lindau may develop an endolymphatic sac tumor. And so the endolymphatic sac is a part of the inner ear. Even in 2024, we're really not sure the function of the endolymphatic sac. We think it may have something to do with fluid balance of the inner ear. It may have an immune function of the inner ear, but for whatever reason, you can develop a tumor of this called an endolymphatic sac tumor. And like I mentioned, it's about 10 to 15% of patients will develop this tumor. The symptoms are typically hearing loss. Patients can also get dizziness or vertigo. You get ringing in the ears, and these are the sort of typical symptoms. But a lot of times they can be asymptomatic. And so part of the screening at age 15, patients with VHL are going to get an MRI to look for an endolymphatic sac tumor, hemangioblastomas, and other, but we'll include that. And you can sort of see here showing on your right side is going to be an MRI, and that's a larger endolymphatic sac tumor. This patient probably has symptoms. And on the left side is going to be a CT scan. And so really screening, the MRI that you would get for the hemangioblastomas and other tumors would typically find a small endolymphatic sac tumor. And if you look at this little cartoon here, this is kind of the location. This is behind the ear. This is the mastoid, which is if you kind of feel under the ear, that's where the mastoid bone is. And this is the inner ear. And this is where the endolymphatic sac is located. And you can sort of see sometimes, well, typically we would recommend removing these tumors because if you're fortunate enough to have these tumors diagnosed before you have hearing loss or before you have significant hearing loss, we can oftentimes remove the tumor without a chance of recurrence and preserve the hearing. So it's nice if we can diagnose these early. So I think it's why it's important to get the screening done at 15 and then continuing, we'll look for these tumors. And so this is kind of showing the surgery. It's a surgery that lasts a few hours, keeping the hospital a day or two, but overall typically well tolerated. And then that's really all I had for that. So screening wise for us, fortunately, we have a very good VHL program. And so typically the scans are done. And once a patient's diagnosed with endolymphatic sac tumor, they'll come see us. I do recommend any patient with VHL get an audiogram every year or two. I think the guidelines say every other year, just so you can pick up some subtle hearing loss. And that would prompt maybe a really careful look at that area to make sure you don't have an endolymphatic sac tumor. So thank you.
Thank you very much, Dr. Kutz. I work with Dr. Margulis clinic. Dr. Margulis, appreciate Nirjala, who works with me very well in coordinating the care that your patient needs. In terms of BHL screening, sir, how do you screen your patients, and are there any signs of symptoms that they need to look forward to or reporting it to you?
So, several questions to unpack here. I think that the signs of kidney cancer or kidney tumor could be blood in the urine, pain on the side. You sometimes feel a mass when they're big enough. That's pretty rare. Most of the time we find these on cross-sectional imaging. So CAT scan or an MRI of the abdomen, usually done with contrast. So we can know that these tumors are enhancing, they're picking up the dye that we infuse intravenously. And so once we find a kidney tumor, we'll get into management, I think, later. But once we find it, in terms of how often do we do it, really depends on, how many tumors we find, the size, the trajectory of the disease, prior history of, treatment, et cetera. But so somewhere, at least once a year, I would like to have some sort of cross-sectional imaging of my patients to see how their kidney tumors are doing if we're observing them.
Well, thank you, Dr. Margulis. Dr. Hamidi, nice to see you in person for the first time. I know we've been exchanging emails with each other, but this is my first time meeting you. BHL lists multiple recommendations for screening for endocrine tumors. What does typical adrenal screening look like, and why are there so many different ways to screen them?
Hi, everyone. I'm also very excited to be here. And just a little disclosure, I am an endocrinologist. I'm not a surgeon, so you will never find me in OR. But I am a hormone doctor. So when it comes to me seeing patients who have EHL, what I screen for is these tumors called pheochromocytomas, or in short, we call them PHEOs. And these are adrenal tumors. Usually they are in adrenal glands. Sometimes they're outside of them, that can overproduce catecholamines. And catecholamines are adrenaline hormones. So these are hormones that cause fight or flight reaction. If you see a bear and you have the reaction to a bear by wanting to run away, you get sweaty, your eyes dilate, and heart rate goes up. And so those are the symptoms that we would expect from high adrenaline levels. So the way screening works is we start at age 5 and continue screening yearly until age 65. And by screening, I mean, these are blood tests that are done, sometimes also 24-hour urine collections to check adrenaline levels. And usually if we see those tests on a blood test, typically we don't have to do the full 24-hour urine collection, which is usually something that my patients are not excited about. So that's one way to screen. We also screen by checking blood pressure, because high adrenaline levels, when that happens chronically, can cause high blood pressure and oftentimes spikes in blood pressure. So blood pressure can be normal, then elevated, normal, elevated. Patients also are educated on paying attention to symptoms. As I mentioned, these would be, we call it spells, because they start out of nowhere and patients can have dizziness, sweaty, they feel pale, clammy, blood pressure can spike up, heart rate can go fast. So those are the symptoms that can be associated with these tumors. But with that said, at least half the time we actually catch these tumors before any of the symptoms. And that's something that is, the quicker we can find these tumors, the quicker we can resect them, the safer it is for the patient.
All right, thank you, doctors. So we have done with the screening, treating signs and symptoms. On the previous session, we have talked about treatment with belzutifan. Now, I would like to get your input on how we would treat a patient if belzutifan is contraindicated. Dr. Barnett, can you talk us through treatment for hemangioblastoma, please?
Sure. Most hemangioblastomas occur in the cerebellum. Cerebellum is important for balance and coordination. So if patients become symptomatic from their hemangioblastomas, they usually develop some balance or coordination problems. And so for patients that, either don't tolerate belzutifan, they have failed belzutifan, or their treatment is progressing anyway, or they're becoming symptomatic, sometimes surgery is recommended. You want me to talk about the surgery at all, or? Yeah, so generally, surgery is done on an inpatient basis. An incision is made over the back of the head, the cerebellum's at the base of the skull. A piece of bone is taken off called a craniotomy, and then we localize and take out the hemangioblastoma. These classically have a large cyst associated with them. It turns out that the cyst is not part of the tumor. It's just that the tumor itself makes fluid or leaks fluid, and so the cyst actually will go away if you've taken the tumor out. So once the tumor's out, we close everything back up. Most patients are in the hospital for 2 or 3 days after that. It's typically effective at relieving those symptoms. The cerebellum is a very forgiving part of the brain, and so many patients have a pretty rapid relief of those symptoms if it wasn't that.
Thank you, Dr. Barnett. Dr. Kutz, you have spoken earlier regarding endolymphatic sac tumors. How would you approach that?
Yeah, so as I mentioned before, we typically recommend, if we diagnose an lymphatic sac tumor, probably recommend removing it, even with normal hearing. A lot of tumors will watch for a while to see if they grow, but again, if we can intervene early, we have a better chance that patient's going to have preserve their hearing long term. Okay, and so if we're lucky enough to find that when the hearing's still good, we have a pretty high success rate of preserving the hearing. Let's say that a patient has a larger tumor and they've already lost their hearing. We can remove the tumor and then we could do a cochlear implant. And most patients with a cochlear implant are really going to do well. They're going to understand speech. Most patients are able to talk on the telephone. And so the one thing to, I think, leave, if you're kind of worried about, what if I get bilateral lymphatic sac tumors, am I going to be deaf? That would be extremely unlikely. Thank goodness we live in the 21st century, because we do have cochlear implants, and I've performed that in patients with VHL and lymphatic sac tumors with good results. The surgery itself, it's a similar incision kind of behind the ear, remove the bone, like I mentioned, the mastoid bone, and then find the tumor. Most of these are pretty limited to the inner ear, but they do involve the dura, and the dura is sort of where Dr. Barnett and I will work together. So oftentimes I'll do this case with Dr. Barnett as co-surgeons, and he'll help resect some of that dura, or if the tumor's bigger, help resect things on the other side of the dura. That's sort of where my expertise stops, and so we'll do a lot of these cases together. Yeah, and fortunately, like I said, many patients never develop these, but if you do, there's some very good options. And I think the biggest thing is, the surgery, you're in the hospital a couple of days, and usually it's very well tolerated. And again, even if the hearing's lost, we can perform a cochlear implant. Most patients are going to still be able to hear.
Right. Thank you. Dr. Margulis, how would you approach this on the urology side of things?
So as a urologist, I end up dealing with the kidney tumors and adrenal tumors. And I can tell you that the belzutifan folks probably going to put me out of business pretty soon, because the amount of operations that we end up doing is significantly decreased over time. As you saw some of the graphs, before and after belzutifan, there's a drastic reduction in number of surgeries that we do. But as a urologist, I have a lot of tools available at my disposal for kidney tumors. And again, it's just important to know that I think in no case really the surgery should be the upfront treatment anymore. So most patients are able to tolerate belzutifan and it has fantastic results. But in cases where tumors progress or patients can have belzutifan, then again, I have some tools at my disposal. Remember, kidney and adrenal are functional organs. So kidney has a lot of important functions. And so I have to balance in my practice. On one hand, we don't want these kidney tumors to spread because once they spread and metastasize, the diagnosis is different. On the other hand, we don't want to operate too frequently because, keep cutting these tumors out, you're going to end up with no kidneys. And so I have to balance that. And so the general rule is once we see this tumor is getting close to 3 centimeters and over, although there's nothing magic about 3 centimeter size, but once they get a little bit over 3 centimeters, we start to see some metastases. And so generally, if these tumors get over 3 centimeters in size, we perform surgery. The surgery can be done laparoscopically, so small incisions, and we can remove all visible tumors within a kidney. I've done cases where I've removed 8 to 10 tumors from each kidney because once you're there, I might as well get everything out that you can. We don't have to go back because the next time to go back in and do surgery, it's going to be a lot more complicated. So the surgical approach is again generally minimally invasive and can be done repeatedly. Can be done safely so that the kidney function is preserved. In some cases, you don't want to operate again. So I've had several patients that have operated on 4 or 5 times, and it's not easy to go back in. But we have things like radiofrequency ablation, cryotherapy, and now radiotherapy that can be used to stabilize growth of some of these tumors. So we have quite a few tools at my disposal. Same thing for the adrenal glands. You only have 2 adrenal glands. The pheochromocytomas can be bilateral on both sides. And so there are techniques described where we can go in and remove just the part of the adrenal gland that has the tumor so that we preserve some of the normal adrenal function.
All right, piggybacking on adrenal glands and endocrine tumor, Dr. Hamidi, how would you treat your patients if they're not eligible for belzutifan?
So I actually have an anatomy lesson for you. Let's see how that works out. Okay, so when I talk about adrenal glands, most people are like, where are the adrenal glands? I'm like, they are a little lower down. So let me show you actually where they are. And this audience might know where they are, but at least I wanted to start with the basics. So this is a CAT scan kind of cutting through the belly area. And what I'm showing you here is adrenal glands that are marked right here with the arrow sign. On the right side, you see a small adrenal gland, looks like a V, inverted V, and it's kind of tucked in right above the kidney, like a little beanie cap next to the liver. So that's your right adrenal gland. And on the left side, it's more of a shape of a croissant, so it's a little bigger and it's inverted Y. And it's also right above the kidney, kind of closer to the center. So they're tucked in, like I said, like 2 little beanie caps on top of big kidneys. So these are healthy looking normal adrenal glands. As I already mentioned where they are and the shape and the size, all of these details about them. But I also wanted to show you now a different view of how they look and also just this little figure to make that a little easier to visualize. So now we are basically standing up the patient, so to say, and looking at their adrenal glands. You see 2 big kidneys. This is the right kidney, left kidney, and adrenal glands are right on top here. This is the right one and this is the left one. So this is just to give you a sense of how they would appear. And I already mentioned from endocrine standpoint, we are monitoring blood pressure, adrenaline levels, and periodically check scans as well to find these. Now, from my understanding, patients in this group or people in this group are well familiar with each other to the point sometimes if I showed you the scan, you will know who that is in the room. So with that disclosure, I'm going to show you a scan, but it's not a patient who has VHL, but it's a patient who has a pheochromocytoma, just to show you what we are looking for. So this was a young patient who had a pheochromocytoma, and I just wanted to show you what we would find on their scan. This is a right adrenal tumor, pheochromocytoma specifically. It's quite large here. And also sometimes we look at we get PET scan to see, to kind of confirm or maybe look for other tumors, and you can see that nicely lit up on a PET scan as well. And in this particular patient, also the blood test, like I told you earlier, metanephrines, show that there's a very high elevation of norepinephrine, and this is also the pattern we see with VHL as well. This predominant norepinephrine elevation kind of goes along with the diagnosis. And this is what causes a lot of symptoms that I described earlier. So thankfully, again, this is not a patient with VHL, but this is something that we can see. What's unique with VHL is that those tumors can be on both sides. And sometimes we do attempt to do cortical sparing surgery, which is to preserve as much healthy adrenal gland as possible. But if we cannot do that, or if that procedure was attempted not successful, the patients can end up having adrenal insufficiency. Usually this happens when both adrenal glands are removed or there's a tumor on both of them. And those patients would be then followed up by endocrinology for hormone replacement therapy, specifically with steroids, called hydrocortisone and fludrocortisone. And that's something that as an endocrinologist, I'm very, very familiar with. So if that happens, certainly we have the tools to then treat lifelong adrenal insufficiency as well. So although that's not ideal, but we do have medications that can be given safely, and patients may require them for the rest of their life. So those would be my strategies. Another thing that I wanted to kind of bring up is that when we are preparing these patients for surgery, we use specific medications to block them, to prepare them for the surgery, so that when they're getting their surgery, getting anesthesia, these adrenaline levels don't go up really, really high from stress, from some medications that can activate them. So in order to do this safely, the patients would take medications that we use actually for enlarged prostate, which is kind of interesting, but that basically works similarly by blocking adrenaline levels. And typically this is something that happens 2 weeks before surgery when we start these medications and increase them almost every day based on blood pressure readings, based on symptoms, until the day of surgery. And then the patients can have surgery safely. And after the surgery, typically we stop them. And that in that case, the surgery can be done safely. Before we were doing that, actually, that really significantly increased the patient of unfortunately dying during the surgery because of the really high adrenaline levels. So now we can do it pretty safely, and we have extremely experienced surgeons who know exactly how to approach these tumors. So it's a team effort, but in my clinical practice, I prepare patients for these kinds of symptoms on an ongoing basis. Usually it's at least one patient that we are getting ready for these surgeries. So thankfully at UT Southwestern, we have a team that is really familiar with these otherwise rare tumors. So hopefully that demonstrates what endocrinology can do to offer patients to get them ready for surgery, and even after surgery, how to help them recover and sometimes treat adrenal insufficiency as well. Thank you.